Medicos. Good day to all of you. This is Dr. BK for you, and today I am proceeding with a pelvis. So we have actually completed the abdomen. So the abdominal wall, abdominal viscera, then the major blood vessels, nerves of the abdomen. Now we are proceeding to the pelvis. Now, so in this class, I will be giving a short introduction about the pelvis, the bony pelvis, the bones forming the pelvis, and the various measurements of the bony pelvis. Then I will be discussing in detail about the pelvic diaphragm. Our learning objectives for today will be, so a definition of the pelvis and how do we classify the pelvis broadly, the broad classification, and then followed by that the position of the pelvis, the various measurements of the bony pelvis, inlet, pelvic cavity and outlet. Followed by that, I will be discussing about the difference between the male and the female pelvis. And finally, I will be talking about the pelvic diaphragm. So how the pelvic diaphragm, its constituent parts, origin and insertion, its function, its modifications and evolution of the pelvic diaphragm. To start with, pelvis in Latin means basin. So that is the term coined for pelvis, originates from the Latin. The bony pelvis mainly consists of the two hip bones on either side, the ilium, ischium and the pubis, laterally, and posteriorly what we have is the sacrum and coccyx, which is your lower part of your vertebral column. Sacrococcygeal part consists of sacrum. One piece of sacrum is a fusion of 5 sacral vertebrae, and coccyx is a fusion of 4 coccygeal vertebrae. So the bony or the skeletal part of the pelvis, mainly it is formed by the two hip bones laterally and the sacrococcygeal part, and it is supplemented by 2 ligaments also contribute. One is the sacrotuberous ligament and the sacrospinous ligament. The hip bone and the sacrococcygeal part are actually articulated by their sacroiliac joints. Sacrum articulates with the ilium through sacroiliac joints, and the two pubis are articulating anteriorly in the midline by the pubic symphysis. This is not a synovial joint, pubic symphysis. It is a secondary cartilaginous joint. So, from the walls, laterally, anteriorly and posteriorly, muscles arise from the wall of the pelvis. They form the lateral wall of the pelvis. The muscles which is arising from the lateral wall of the pelvis also sweep downwards and closes the pelvis from below, forming the pelvic inlet, forming the pelvic diaphragm. And some of the muscles of the lower limb also takes origin from the bony pelvis, and these muscles are covered by a fascia, and that fascia is actually called as the endopelvic fascia. The fascia not only lines the muscles forming the wall of the pelvis, they also reflect to the viscera in the pelvic cavity. Okay. So bony pelvis by the hip bone, sacrum and coccyx. Then you have the two joints and two ligaments, sacrotuberous ligament and sacrospinous ligament. The wall, apart from the bones, are actually also formed by the muscles and the fascia covering these muscles. Now, mainly, what is the function of this pelvis? So, mainly during standing, your weight is transmitted from the trunk to the lower limb. It is via the pelvis or the bony pelvis, because the center of gravity, it acts from the head. If you start neck, then to the vertebral column, it comes to the sacrum. From the sacrum, the weight is actually distributed to the inner sides of the hip bone, and from there it is transmitted to the femur or lower limb. So it is involved in weight transmission during standing. Not only during standing, definitely even during sitting. Because again, from the sacrum it is transmitted to the hip bone, and the ischial tuberosity or the part of the hip bones which rests on the surface when we are sitting. So the weight is transmitted from the bony pelvis to the ischial tuberosities. So even during sitting, they are involved in weight bearing. So since man has obtained erect posture, and because of this, what happens is the whole of the thrust is felt on the pelvis. So that is why you need a strong bony framework. Not only that, your abdominal organs, stomach, jejunum, ileum, all those things, liver. So the weight of these organs, the pressure exerted by these organs are also transmitted to the pelvis, from the inlet to the cavity to the outlet. So that is why we need a strong pelvic diaphragm to counteract the forces exerted from above, that is from the abdominal cavity. Okay. Then the pelvis also lodges the organs, pelvic organs, viscera, mainly your genitourinary system in the lower part of the GIT. Below the sigmoid colon, rectum, anal canal, your bladder, the urethra, uterus in case of females, with ovary and the fallopian tubes are all lodged inside the pelvic cavity. Okay. Accommodates the lower part of the alimentary tube and the urogenital organs. So it is also protective in nature. Apart from weight bearing, the bony pelvis is actually protective in nature. Then, apart from that, it provides attachment for the muscles of the trunk and the lower limb and the pelvic diaphragm. This I have just described in the last slide I have discussed. Apart from that, it accommodates the fetal head. In the gestation, the third trimester of the gestation, and just before the parturition, what happens is the fetal head rests on the pelvic diaphragm. Then, examination of pelvis and various dimensions, measurement of the various dimensions of the pelvis, pelvimetry, is helpful in obstetrics. So whether the labor will be a smooth labor or whether certain complications can be expected in a child labor. Okay. childbirth. Child labor here in the sense it is childbirth. That by looking at the pelvis sex determination, pelvic bone, whether it is a male pelvis or female pelvis, age of the person also can be determined. Anthropological. Again, by looking at the shape of the bones, it can be determined whether the bones belong to certain ethnic groups or whether they are Asians or Europeans or Caucasians. Evolution can also be determined based on their anthropological aspects, and of course for certain medico-legal importance also, the knowledge of the pelvis and the pelvimetry is essential. Now, broadly, if you look, the pelvis, you have the pelvic inlet. The pelvic inlet slopes downwards and forwards. It is actually oblique, inclining downwards and forwards. Now, because of that, the part of the hip bone above the pelvic inlet is actually called as the falls or greater pelvis. The falls or the greater pelvis, on either sides you have the iliac fossa and the iliac crest. Anteriorly, the bony wall is deficient. The bony wall of the greater pelvis is deficient, and it is actually the anterior abdominal wall which forms the anterior wall of the greater or the false pelvis. So the greater or the false pelvis lie above and in front of the pelvic inlet, so mainly formed by the iliac fossa and the upper surface of the lateral mass of the sacrum, which is called as the ala of the sacrum. Okay, so that is the difference between the greater or false pelvis, which is above the inlet. Below the inlet only we have the lesser pelvis or the true pelvis, which has the pelvic cavity which lodges the viscera, your genitourinary and the lower part of the GIT is actually present within the lesser pelvis. So true pelvis is actually below and behind the greater pelvis, below and behind the pelvic inlet. So this is actually called as the pelvic inlet, or it is also called as the pelvic brim. It is also called as the pelvic brim. So this is uppermost border of the true pelvis is also called as the pelvic brim. It resembles a true basin, and the outlet is actually closed by the muscles which forms the pelvic diaphragm. Inlet is open, but the outlet is closed, and it has certain openings for transmission of the genitourinary and the part of the lower part of the GIT, gastrointestinal tract. So this pink color shaded one is the false pelvis. On either side we have the iliac fossa and muscles arising from that iliacus muscle. This is the inlet or the pelvic brim. Below that you have the pelvic cavity and the pelvic outlet, which is closed by a muscular diaphragm, that is the pelvic diaphragm. Below the pelvic diaphragm, this area is actually called as the perineum, where your external genitalia is located. That region is actually called as the perineum. So as I told you, the true pelvis resembles an inlet, a cavity and an outlet. The true pelvis. Now coming to the pelvic inlet, as I told you, it is also called as the pelvic brim. It is formed by a continuous line by the sacral promontory, anterior margin of ala of sacrum, followed by this line is the linea terminalis, which is formed by the arcuate line of the ilium, iliopubic eminence, arcuate line of ilium, iliopubic eminence. Then you have the pecten pubis. This is actually called as the pecten pubis and pubic crest. The sharp upper border you see on the superior ramus is the pubic crest, and then the upper end of pubic symphysis. So if you draw a continuous line from the sacral promontory, anterior margin of ala of sacrum, linea terminalis, west of arcuate line, iliopubic eminence, pecten pubis and pubic crest and upper part of pubic symphysis forms the pelvic inlet. I told you the pelvic inlet is not in a transverse plane, it actually slopes downwards and forwards. Slopes downwards and forwards and makes an angle with the horizontal plane around 50 to 60 degrees, so naturally approximately 55 degrees. The plane of pelvic inlet makes an angle with the horizontal plane at 55 degrees. If you draw a line perpendicular to the plane of pelvic inlet, that is actually called as the axis of inlet. If you prolong this, it will actually extend to the umbilicus. Your uterus line lies along the axis of inlet. Your normal anteverted antiflex uterus lies in line with the axis of inlet. Okay. The measurements, if you look, the inlet has a antero-posterior measurement, transverse measurement and an oblique measurement. Antero-posterior diameter, transverse diameter and an oblique diameter. Antero-posterior diameter is from the sacral promontory to the upper part of pubic symphysis, upper border of pubic symphysis. Okay, so that is the antero-posterior diameter, which is 4 inches in case of males and 4.5 inches in case of females. The transverse diameter is the widest diameter along the inlet. So if the inlet you series of measurements and the widest diameter, which will be 4.5 inches in case of females and 4 3/4 quarters in case of females. 4.5 in males and 4 3/4 quarter in females. The oblique diameter from the sacroiliac joint of one side to the iliopubic eminence of the opposite side. Sacroiliac joint of one side to the iliopubic eminence of the opposite side gives the oblique diameter, which is 5 inches in case of males and 5/4 inches in case of females. So if you look at the dimensions of the inlet in case of females, it is wider than the males. The pelvis itself is wider in case of females. One more conjugate you have, which is called as the obstetric conjugate, is the minimum antero-posterior diameter. So you take it from, instead of from upper border, you take from the inner part of pubic symphysis to the sacral promontory. Inner part to the sacral promontory, minimum antero-posterior diameter gives the obstetric conjugate which is 0.5 centimeters less than the anatomical conjugate from behind the pubic symphysis to the sacral promontory. The shape of the inlet, if you look in case of males, it is heart shaped. It is heart shaped and it is called as the android pelvis. It is actually called as the android pelvis. The heart shape is mainly because of the sharper anterior border of the sacral promontory in case of males. And posteriorly it is wide, anteriorly it is narrow. Posteriorly it is wide and anteriorly it is narrow. That is why it assumes a heart shape in case of males, which is called as android pelvis. In females it is round, both anteriorly and posteriorly it is wide, and that is called as the gynecoid pelvis. Gynecoid pelvis is round in shape, anterior and posterior diameters. The transverse diameter is more, and the anterior wall and the posterior wall, posterior and anterior wall of both the walls are actually equal. They are wide. The next is at birth, ovoid pelvis. The antero-posterior diameter is more than the transverse diameter. That is called as, at birth, it is called as anthropoid during birth. But then after puberty, what happens is it assumes the adult shape based on the growth. If it is a female, it assumes a round shape. How it assumes a round shape is the pubis also goes transversely more. But here, what happens in case of males, the vertical growth of the lateral wall of the pelvis is more than the growth of the pubis. So it assumes a heart shape. This is anthropoid pelvis. The anthropoid pelvis. Next is platypeloid pelvis or flat pelvis, where you can see abnormally large transverse diameter. So antero-posterior diameter is very much reduced and the transverse diameter is exaggerated in case of platypeloid pelvis. So if it is not a round pelvis, if it is oval or android pelvis, then naturally what happens? Some difficulty in labor in such woman. There will be a difficulty in child labor. And platypeloid or flat pelvis is also seen in rickets and osteomalacia. Coming to the pelvic cavity, deep to the inlet, what you see is the pelvic cavity. It extends downwards and backwards from the inlet. It extends downwards and backwards from the inlet, and extension from the inlet to the outlet. So in front it is mainly formed by the posterior surface of the body of the pubis and the rami. Laterally, what you see is the lateral wall of the pelvis, the pelvic surface of the ilium. Okay, in front pubic symphysis, body and the ramus of pubis. Behind you have the sacrum and the coccyx. So posterior wall of the cavity is formed by the sacrum and coccyx, and as I told you, pelvic surface of ilium and ischium forms the lateral wall of the cavity of the pelvis. If you look at the shape of the cavity of pelvis, in case of females, it is cylindrical in nature. It represents a short section of a long cone. Take a very long cone and just take a short section. It is cylindrical. So that means it is wider. The pelvic inlet, outlet, and also the cavity. Whereas in case of males, it is actually conical. It is actually conical. If you look at the outlet, diameter is actually less than the inlet diameter. and it represents the long section of a short cone. Okay, you take a short cone and you make a long section. So very long section if you take, then you get a cylindrical, you get a conical shape in case of the males. The cavity is longer and conical in case of males. In case of females, it is cylindrical. Okay, so these two difference between male and female pelvis you should know with respect to the cavity. And I told you because how it assumes the cylindrical, because both the pubic bones grow transversely in case of the females, and the subpubic angle is also wide. In case of females, it is wide, the subpubic angle, whereas in case of males, the subpubic angle is narrow. Antero-posterior diameter is actually taken from the S3, middle of the sacrum, third sacral vertebra to the middle of the pubic symphysis. That is the antero-posterior diameter. Then transverse diameter along the lateral wall of the pelvis. Along the lateral wall of the pelvis, the transverse diameter is measured, and the diagonal conjugate is measured from the middle of sacroiliac joint or the lower part of sacroiliac joint to the obturator membrane. The middle of the lower part of sacroiliac joint to the obturator membrane is the diagonal conjugate. Next, coming to the pelvic outlet, it is a diamond shape. It is mainly formed by the lower border of the pubic symphysis, inferior ramus of pubis, conjoined ischiopubic rami, and behind by the tip of coccyx. Okay, so inferior ramus, conjoined ischiopubic rami, tip of coccyx. Between the ischial tuberosity and the sacrum, it is again formed by the sacrotuberous ligament near to the outlet. Again, the outlet is wide in females because of the wide subpubic angle, which is 80 to 90 degrees in case of females, whereas in males it is around 50 degrees, narrow subpubic angle. And the outlet, if you look at the outlet, it is a meeting point of two planes. So here you can see it is the meeting point of two planes. Anterior part of the outlet slopes downwards and backwards. Posterior part of the outlet slopes downwards and forwards. So the meeting point is actually, and if you draw a line, it meets the horizontal plane at an angle of 15 degrees. But for all practical purpose, we cannot have a two planes. So it is actually the plane which is extending from the tip of coccyx to the lower part of the pubic symphysis. Okay. So backwards and downwards, posterior part is forwards and downwards. So plane of outlet for all practical purpose is from tip of coccyx to the lower part of pubic symphysis. Tip of coccyx to the lower part of pubic symphysis. And if you draw a line perpendicular to the plane, that forms the axis of pelvic outlet, and this axis coincides with the vaginal canal. Vaginal canal lies along the axis of pelvic outlet, whereas uterus lies along the axis of pelvic inlet. So if you take the axis of the pelvic cavity, pelvic inlet, pelvic outlet, we have discussed pelvic cavity, it is a meeting point of two axes. Axis of inlet and axis of outlet. Okay. And you cannot have a single axis of the pelvic cavity. The axis is actually concave ventrally. It follows the axis of the sacrum, the axis of pelvic cavity. What I mean here is, so the dimensions of the pelvic outlet Antero-posterior is from lower border of pubic symphysis to the tip of coccyx. And transverse diameter, when you measure the two ischial tuberosities, transversely you measure the two ischial tuberosities. Okay, and then you also have the diagonal conjugates, which is from the ischial spine. From the ischial spine, you measure to the opposite side. So the anteroposterior diameter again is it is 5 inches in case of females. So it is actually 5 inches. In case of males, it is only 3/4. So that is why the pelvic cavity is conical in shape. Oblique diameter and then the transverse diameter. Oblique diameter is 4.5 and transverse diameter is again 4.5 in case of the pelvic outlet. So all dimensions of the female pelvis, whether it is inlet, cavity or outlet, it is wider or slightly but significantly larger than the male pelvis. So as I told you, the axis of pelvic cavity follows the sacrococcygeal curve. It follows the sacrococcygeal curve, and the upper part is actually downwards and backwards, and lower part is downwards and forwards. So coming to the difference between male and the female pelvis, to just concise, inlet is heart shaped, here it is round, cavity is conical and long. The vertical part is long, whereas here the cavity is cylindrical and short. Outlet is small and 1 inch less in all diameters than that of the female, whereas outlet is wide and anteroposterior diameter is the longest diameter in case of the female pelvic outlet. Subpubic angle is narrow, which is around 50 to 60. Here it is subpubic angle is wider. Long and narrow sacrum. Ischial spines are interned. Tuberosity and ischial spine are interned. Sacral index is about 105. Here short and wide sacrum. So that is why the cavity itself is short. Ischial spines are actually, sorry, it's not interned, it is outturned here. And sacral index is 115. Sacral index, when you divide the length and breadth, length divided by breadth into 100 gives us sacral index. So shape, heart shape in case of males. Females, it is wider or round shape. Cylindrical cavity, wide subpubic angle. Here it is conical cavity, narrow subpubic angle. Here anteroposterior diameter is more in case of anthropoid, and platypoid the transverse diameter is very much exaggerated. See, the subpubic angle is very much wide in case of the platypoid pelvis. So we'll have a quick look at the sacrum. It is a fusion of 5 sacral vertebra. It's a flat wedge-shaped bone which has got a base, apex, anterior surface which you see in the front, you see the posterior surface and 2 lateral surfaces. So articulates with the ilium to the sacroiliac joint. To the apex, it articulates with the coccyx and the base with the L5 vertebra. If the L5 vertebra is completely fused, it is called as sacralization of lumbar vertebra. If yes, first sacral vertebra is not fused, unfused one, if the first sacral vertebra is not fused with the rest of the sacrum, it is called as lumbarization of sacral vertebra. Okay? One is sacralization, other one is the lumbarization. So anterior, posterior, 2 lateral surface, it has got a base and an apex. And behind you also see a canal which is called as the sacral canal. Base is formed by the upper surface of the first sacral, articulates with the the lumbar vertebra, and the anterior border of the sacrum is sharp and is called as the sacral promontory. On either side you see the lateral mass, which is called as the ala of the sacrum. On either side what you see is the ala of the sacrum. They are the fused costal elements. So that is the transverse process or fused costal elements, and it is called as the ala of the sacrum. Apex bears an oval facet for the coccyx to form the sacrococcygeal joint. So that is the fan-shaped ala of the sacrum, which is the fused costal element, and that is the sacral promontory. Pelvic surface is concave, and in males it is uniformly concave. In females, what happens is it is somewhat vertical and lower part becomes abruptly concave. In the midline you see the ridges, 4 ridges, which is the line of fusion of the 5 sacral vertebra. This is anterior sacral foramina, through which the ventral divisions of the sacral spinal nerves will come out. On the dorsal surface you see a crest, fusion of the lamina, which is called as the dorsal sacral crest or median sacral crest, fused spinous process. Lateral to this we have the fused lamina. Lateral to the median sacral crest you have the fusion of the lamina of the sacral vertebra. The 5th sacral vertebra alone lamina is not fused and shows an inverted U-shaped opening, which is called as the sacral hiatus. Sacral hiatus. And this hiatus is guarded laterally by this lower edge of the unfused articular process, inferior articular process, called as the sacral cornua. So these two are actually called as the sacral cornua, which is the unfused part, inferior articular process. Sacral hiatus is the non-fused part of the lamina of the 5th sacral vertebra. So above you see the sacral canal, which is the vertebral foramen of the sacral vertebra. It is transformed into a canal because the remaining the spines are fused, and what is transmitted through that is the meninges. Okay. Mainly it transmits the meninges, that is the phylum terminale. Then spinal nerves, lower sacral nerves, cauda equina. They resemble a horse tail and they travel vertically. And the meninges. Okay. This sacral canal communicates with the dorsal sacral foramina through the intervertebral foramen. And the lateral sacral vessels are also emerging through the sacral canal. So we have seen about the sacrum in short. Now we will move on to the pelvic diaphragm. So the pelvis, the term itself means basin because below it is closed by the muscles. A gutter-shaped muscular partition extends across the outlet, so closes the outlet and forms the floor of the pelvis. This is superior view, this is actually inferior view, and it has openings for the transmission of the vagina and the urethra in case of females, urethra alone anteriorly in case of males, and posteriorly it transmits the lower part of the rectum. So it separates the pelvic cavity. Below the pelvic cavity on either side on the perineum you have the ischio-anal fossa or ischio-rectal fossa. So that is separated from the pelvic cavity by this pelvic diaphragm. It is mainly made up of two muscles, levator ani and the coccygeus. And this is again lined by the fascia of pelvic diaphragm. Superior fascia lines the inner aspect and outer aspect is lined by the inferior fascia. outer aspect, you look at the muscles. You are also able to see an intersection of muscles here, which is called as the perineal body, and this is actually from the anal canal to the coccyx, which is called as the anococcygeal raphe. You know what is this one? Sacral hiatus, sacral cornua, median sacral crust. Just now we saw in the last slide with respect to the sacrum. So as I told you, the openings, it is pierced by urethra in males and urethra and vaginal canal in case of females. Levator ani muscle, the gutter shape is mainly formed by the levator ani muscle. It arises from the pelvic surface of the body of the pubis. Okay, and also from the white line. So here you are able to see a white line or tendinous arch. It is the thickening of the obturator fascia covering the obturator internus. But originally it is the fascia of levator ani. The levator ani has actually migrated from a higher level to a lower level because of the weight bearing, and its original point attachment is by the tendinous arch of the white line. So arises mainly levator ani from the pubis, tendinous arch, ischial spine, and the fibers, they slope downwards and backwards. Three sets of fibers from anterior to posterior, you can see. Pubococcygeus more anteriorly, iliococcygeus posterior to it, and then ischio-coccygeus more behind, posteriorly, and the iliococcygeus followed by the ischio-coccygeus. The ischio-coccygeus is the coccygeus proper muscle, whereas the pubococcygeus and iliococcygeus belongs to the entity of the levator ani. So, as I told you, pubococcygeus and iliococcygeus part. Iliococcygeus part and pubococcygeus part are entity of levator ani, and that is the tendinous arch of white line. And this is your obturator internus muscle. So, pubococcygeus part mainly from the anterior part of the levator ani, and some of the fibers are inserted into the perineal body as pubovesicalis, levator prostate. In case of the males, it passes by the side of the urinary bladder and prostate as the levator prostate. And some of the fibers are attached to the wall of the vagina as the pubovaginalis muscle. Okay, the pubovaginalis muscle, it is attached to the wall of the vagina. This is female pelvis. This half is the male pelvis, where it forms the puboprostaticus. The pubovaginalis, since it is attached to the wall of the vagina, it is also called as the sphincter vagina. It constricts the vagina so that prevents the prolapse of the uterus. So above you have the childbearing organ, the uterus. Due to increased intra-abdominal pressure or weight-bearing gravity, due to the gravity, the uterus might prolapse. To prevent it, some fibers of the pubococcygeus, which is called as the pubovaginalis, insert into the wall of the vagina, sphincter vaginalis. Then, pubococcygeus muscle we are actually discussing. Next is the puborectalis muscle. Forms the middle part of the levator. Anterior part we have seen puboprostaticus or levator prostate and pubovaginalis. The middle fibers, they form a continuous sling which passes by the sides and behind the rectum, especially the anorectal junction. Pass by the side of the anorectal junction. Forms a U-shaped sling which is actually called as the puborectal sling. This is very, very important to maintain this curvature and holds the weight of the feces. If this muscle relaxes, your rectum becomes straight, and what happens? The fecal matter descends into the anal canal. So mainly responsible for maintaining the rectal junction, thereby holding the weight of the feces. Not only that, in the just before the parturition, the child head also rests on this puborectal sling, supports the child head during just before the parturition. That is one more function. So naturally, what happens is if this puborectal sling muscle, puborectalis muscle is disturbed, then you might get rectal incontinence or fecal incontinence. You might not be able to hold the fecal matter. Prolapse of the rectum might also takes place. Some of the fibers, apart from forming the puborectal sling, is attached to the lateral wall or merging the longitudinal muscle coat of the rectum, and that is called as the puboanalis muscle. So these lower part muscles, puboanalis muscle, which is merging with the longitudinal muscle of the anus. So as I told you, holds the weight of the feces, and fetal head rests just during parturition and its rotation of the head. The posterior fibers, anterior fibers, we have seen as the pubovaginalis, levator prostate. Middle fibers, puborectal sling, Posterior most fibers, these fibers, they form the pubococcygeus muscle or the iliococcygeus, overlap the fibers of the iliococcygeus and inserted into the anococcygeal raphe and tip of the coccyx. So these posterior fibers of the pubococcygeus attaches to this is called as the anococcygeal raphe and also to the tip of the coccyx. Then immediately behind it you have the iliococcygeus, arises from the white line, posterior part of the white line of obturator fascia and ischial spine. On either side you see the ischial spine and the posterior part, and they get inserted into the anococcygeal raphe and to the last two pieces of the sacrum. Okay. So that is your iliococcygeus part from the posterior half of the white line and also from the ischial spine. Anococcygeal raphe is also called as post-anal plate. Anococcygeal raphe extending from the anus to the tip of the coccyx. It is interlacement of muscle fibers. Pubococcygeus, iliococcygeus, and the muscle fibers of external anal sphincter. Your external anal sphincter has got three parts. It has got superficial part, then it has got an intermediate and a deep part. Okay. So this actually merges with the external anal sphincter. Anococcygeal raphe is where the fibers of the pubococcygeus, iliococcygeus and external anal sphincter, they merge. So nerve supply of levator ani is mainly branched from S4 directly and by S3 and S2 via the inferior rectal branch of prudental and perineal nerve. Next, coming to the last muscle of the pelvic diaphragm. So far we have seen about the pubococcygeus and iliococcygeus. Coccygeus proper arises from the ischial spine, pelvic surface of the ischial spine and sacrospinous ligament, and it is getting attached to the coccyx, lower pieces, two pieces of the coccyx. So that is the coccygeus proper muscle. The coccyx bone is long in case of the retrograde mammals and they attach to the tail, so thereby they are responsible for movement of the tail. But in case of humans, what happens? This actually forms the pelvic diaphragm, posterior part of the pelvic diaphragm. But the main brunt of the weight of the pelvic viscera is mainly borne by the anterior part of the pelvic diaphragm rather than the posterior part, because posterior part Most of it has degenerated into sacrospinous ligament. Part of the coccygeus muscle degenerated into sacrospinous ligament. Nerve supply is from 4th and 5th sacral nerve. So mainly the anal canal, when the fecal matter distance, it pushes the coccyx backwards. So once the defecation is over, then what happens is the coccyx comes forward by the contraction of the coccygeus muscle. So puts the coccygeus forward after defecation, and it is responsible for closing the posterior part, contribution to the posterior part of the pelvic diaphragm. So thereby closes the pelvic outlet. So in man, erect posture makes the pelvic outlet a dependent part. So any fluid collections or any weight borne, naturally what happens is the ultimate pressure is borne by the pelvic outlet. So we need a strong pelvic diaphragm. So muscles of the pelvic wall, which were from the lateral part of the wall of the pelvis, have migrated. They sweep downwards and backwards and closes the pelvic outlet, thereby forming the pelvic diaphragm to support the weight of the viscera. So the white line of the obturator fascia, the tendinous arch, is originally not obturator fascia but fascia of the levator ani muscle, which has its origin at a higher level but has migrated to form the pelvic diaphragm in case of humans because of the erect posture. Because the tail has degenerated in man, the muscle of the tail, the coccygeus, contributes to the pelvic diaphragm, but it is not a very active contribution. And most of the coccygeus muscle, they degenerates to sacrospinous ligament. So mainly it supports the pelvic viscera, counteracts the increased intra-abdominal pressure. So mainly during coughing or during vomiting or during constipation, sneezing, or when you take a deep breath, what happens? The diaphragm comes downwards and increases the intra-abdominal pressure. So all this has to be counteracted by this pelvic diaphragm. So it prevents the prolapse of rectum by the puborectal spleen, maintains the curve junction, anorectal junction, and also prevents the pelvic diaphragm holds the uterus, thereby preventing the prolapse of the uterus into the vagina. So pubococcygeus part relaxes and also aids in mixturism, bladder relaxation, and stimulates the detrusor muscle to contract. So that is one more necessary function of the pelvic diaphragm. Opening is hiatus urogenitalis, urethra in males, and vaginal canal and urethra both in case of females. This is called as hiatus urogenitalis. The posterior opening is actually called as hiatus rectalis, which transmits the lower part of the rectum. And one more opening on either side, if some of the levator ani muscles fail to originate from the lateral wall of the pelvis, that is called as hiatus or swallow. It is an abnormal opening, not usually normally present. So then what happens? Some herniation can take place through this hiatus. So damage to pelvic floors, muscles or ligaments mainly during parturition or direct trauma or any surgical procedures like hysterectomy, and if it is not properly sutured, can lead to uterine prolapse. The uterus might descend down through the vaginal canal if the pelvic diaphragm is not very effective. The integrity of the pelvic diaphragm is lost. If the perineal body is not sutured properly, can lead to uterine prolapse. Then, same way puborectal spleen is damaged, it might lead to prolapse of the rectum. Okay. So, it might lead to rectal prolapse. So, rectum might again descend through the hiatus rectalis. Even cystocele, what happens is The bladder actually tries to permeate to the vaginal canal, that is actually called as the cystoscene, and sometimes stress incontinence will not be able to hold the urine, so bladder incontinence might be there if the pelvic diaphragm is actually damaged. So that is all for the pelvic diaphragm. Thank you very much for your patient listening.